I guess I'm not in the middle of lunch, so that's a good thing. It's nice to see everyone. I appreciate the invitation to come back and talk about some of the things that we've been doing at the FAA to move forward in this area of pilot mental health. So, without further ado, I will say that some of these things you probably heard last year. Some of these things we've talked about all morning, and some of these things I expect will be new. So, there we go. I have to emphasize, and I'm sure I don't have to say it to this group, but flying safety is still number one. That is our North Star, as our administrator has frequently said. And that's going to mean sometimes that aviators don't get the answer from us that they really hope for. But it's very clear that this is what we are about, is safety. So, just to let you know what's been going on, as you can see here, the total applications is the line in red. It dipped considerably during the pandemic and now is on a markedly upward trajectory. We are, in fact, on course for 2022 to break our all-time record. We've already exceeded 400,000 applications. So there is a lot of activity going on in medical certification these days. The bottom line is our special issuances. You can see that pretty well follows the trend of the total applications that we get. But this is our formal HIMSS special issuance. These are the folks who are in airline programs, who have a HIMSS chairman, and who are fully invested in the HIMSS program. So these are mostly Class 1 pilots, but you can see the trend toward an increase of folks entering the HIMSS program with a diagnosis of substance dependence is going up in a linear fashion, and it started well before the start of the pandemic. So I don't know what that means. We'll keep watching it. If Quay is out there, and I don't see him, there he is. I don't know quite how to explain this, but we're having more and more folks entering into the HIMSS program. So last year I talked a little bit about mental health, not so much as health and wellness, but to begin to rethink how we think about this and how we talk about this in terms of mental status as a performance issue and as a safety issue. And the example that I talked about last year of the American gold medal gymnast Simone Biles going to the Tokyo Olympics and coming to the realization that something's not right. Mental status, performance, after 5 years of training to go back to that Olympics and maybe do things that had never been done in that competition before, she said, I am not safe. I am not going to do this. And by comparison, fast forward to the Beijing Winter Olympics and the Russian figure skater and all the controversy surrounding her about, maybe use of drugs or whatever, setting aside the political and the cultural issues that may be at stake here, she did not make that determination. She did not recognize that, maybe my mental status is going to impair my performance. She went ahead and competed anyway to very, very disappointing results. So I bring these comparisons frequently to other aviation groups that I talk about, and just a reminder that we may have something to learn from the experience of our elite athletes. So what is the message that we are trying to convey from the FAA at this point? Mental status is a performance issue and a safety issue. And communication promotes recognition. You know, what are we doing here? We're talking about this. And what are we doing when we go out the door? We're talking to other people about it. And so now this conversation becomes more comfortable. And so it sets you up to be able to recognize the problem and then hopefully take action. So what are the big challenges? You know, we talked about this in some of our discussions this morning. Number one, dispel the myths. Number two, destroy the barriers. So how are we working in that direction at the FAA? Well, our philosophy, and I showed this last year again, it's the same as it's been for all 3 federal air surgeons that I've worked for in my career. So in a pilot with mental health diagnosis, return him or her to flying as soon as it is safe to do so. So how do we decide if it's safe? This takes us back to basic SMS. Our folks take a look at these cases, and here are the 2 questions we ask. It's very straightforward. How likely is this to occur again? And if it occurs again, how serious is it likely to be? Basic SMS. But, okay, the questions might be straightforward, but the answers to these questions can be very complicated. And I assure you, sometimes we spend hours discussing a case and saying, okay, you know, where are we here on this? But no big secret behind the curtain, you know, stuff. This is where we go every day in our discussions about cases. So, myth. I need your help with this, you know, and we all, again, talked about it in our discussion groups this morning. Denial is a common event. Oh my gosh, you know, if there's ever, you know, a mental health issue, you know, you're gonna never get your certificate, or if you've got it, you'll never see it again. After the summit last year, we got a follow-up letter with somebody who was a little confused with the statistics that I showed last year, which were, in general, denial statistics. And we decided, you know, in this setting that it made sense for us to try to figure out what the mental health status was in terms of denials and special issuances and so on. So with the caveat that our database that we have is not terribly supportive of research kinds of questions, we did go into the database and we queried, and what we appear to see is that about 20% of initial cases that have a mental health diagnosis, maybe that's not the only diagnosis, but have a mental health diagnosis, about 20% of them are disqualified initially. Okay, that means 80% are going to get their certificates, and I think anybody would take those odds to Vegas, right? But something I need to explain very carefully about this 20% is that that is initial decision. So what do we see? Frequently we get cases through requesting special issuance where the workup is incomplete, or we need some additional information, and so we go back to the airman and say, hey, you know, send us X, Y, and Z, all right? Frustrating to the airman receiving that letter, but if they go out and do those things and send us those documents, very often we can come back and say, okay, we're happy now, here's your special issuance. So that takes down that number of 20%. The other thing that we're seeing a fair amount, and this will be near and dear to your hearts, is a lot of these young aspiring student pilots come in with amazingly complex medical and mental health histories already, you know, and we send them to Dr. Danzig and say, hey, what do you think? And what we conclude is that maybe with a little more observation time, little more demonstration of stability in the condition, that maybe we can get to yes. And so frequently we will say to these individuals, continue your therapy, come back, reapply in 2 years, and let us look at it again. And if everything is looking good and has been stable over that 2-year period, then again, we are very likely to come back with a special issuance to that individual. So a little bit of persistence can earn the reward. Now, What else? Okay, we have for a long time in the HIMSS program said, you make the effort to get into recovery and we will get you back in the cockpit. Full stop, 100% guaranteed. You know, how often do you get a doctor to say always or never kind of thing? But we really have. It doesn't matter if you relapse once or twice or 3 times or 4 times. As long as you put in that effort to get back in good, solid recovery, you will get back in the cockpit. And so at the FAA headquarters, we said, can we find other conditions where we can make that same promise to the airmen? And we talked about anxiety, which is extremely common right now. And here's where we came. You know, if an aviator has uncomplicated anxiety, once they get into remission, we will get them back in the cockpit, another 100%. So hopefully we can get that message out that we don't need to be afraid of this thing. We can deal with it and we can get people back in the cockpit. Okay, how successful have we been? Well, here are the numbers. I don't have them yet from 2021 or 2022, but 1,500 pilots flying with antidepressant medications that would not have been flying before 2010 at all. And over 1,700 with diagnosis of substance dependence who are actively flying that would not have been flying before the HIMSS program was initiated in 1974. So what are we doing? Okay. First of all, we are coming toward the end of a research project that we undertook to see if we were requiring cognitive testing in the SSRI program too often. And the answer is we have concluded, yes, we are. What we have not decided on yet is how frequent that ought to be, but we have already decided that it's more frequent now than it needs to be. So hopefully by the end of this calendar year, which is coming up very rapidly, we will be able to publish a revised standard in terms of SSRI follow-up. Also, we're looking actively at whether or not we ought to allow more different medications for treatment of mental health issues. I know some of our colleagues in other countries as well use other medications that we haven't used. We picked these 4 SSRIs because they had the most benign side effect profile. We've had very good experience with it, so again, we are actively looking at this as a way to decrease the barriers of people getting into the program. Improving processing time. This is probably the big one. Fortunately, today, one of the individuals in our discussion group this morning had a good news story to tell, but I would really like to get to the point where we have an answer on our initial SSRI cases within 30 days. Right now, we're about 6 months out, and I recognize, especially with the young folks in these programs, but also with our pilots who are depending on, flying for their livelihood, that these delays are off-putting, to say the least. And so we are actively working at getting those processing times shortened and getting decisions back out sooner. In that vein, we hired Dr. Danzig last year. He's been with us a whole year. And already we realize that even he is not enough. And so we are looking for, so we are on the verge of hiring yet a 4th psychiatrist for our staff to try and meet the demand that's out there for psychiatric specialty reviews. We've talked about the new decision grids that we've published that allow AMEs to issue individuals with histories of mild depression or adjustment disorder and PTSD, a subset of those folks for the first time. So prior to the publication of those, all of this stuff needed to be deferred to the FAA for a decision. So with a little getting used to it, the AMEs have embraced this, and we've had very positive feedback so far. And I will show you some samples of what those kind of look like here in a minute. Also championing pilot peer support programs. This is like the fourth presentation that I've given over the past 2 months to different groups in support of pilot peer support programs, because that's where the pilots feel comfortable going. And it's very important that the volunteers understand the realities and not the myths so that they can share it with their fellow pilots. And finally, we do have ADHD guidelines that are in revision. We have a neuropsychology special group that's working on developing these. We recognize that especially for the young aspiring student pilots, that this is a diagnosis that can really trip folks up. So, situational depression. These are the criteria that are reflected in that decision grid. I would refer you to the AME guide where it is detailed and laid out, and you could see exactly what the criteria are that the AME is working with in terms of whether he or she is going to be able to issue that certificate right in the office or not. All right, and this is what the decision tool looks like. If everything there is good, you will walk out of the AME's office with your certificate in your hand. All right, post-traumatic stress disorder. Again, these are the criteria. We have a similar decision grid. I didn't think, probably we would need to include that here, but again, I'd refer you to the AME guide. Take a look. We are actively looking at developing more of these, so plenty to do. Let's talk a little bit about ADHD. I know that is a subject of great concern. What do we know? Okay, we know this is overdiagnosed. We also know it's underreported on medical application. But all of these currently are being deferred to the FAA. Again, we are working on what we might be able to use as a decision support tool so that the AMEs may be able to issue some of these. It's also a struggle for our folks, because here's where we get in the midst of this mess. We've got a subgroup of applicants who never had the diagnosis, really. Never really had it, okay? But they get labeled with it because it's the way that their prescribing physician can justify giving them performance-enhancing stimulants, okay? Then we have the group in the middle who did have the diagnosis, who get symptoms compatible with it, who were probably treated appropriately. But then essentially their maturation, they kind of outgrow it, for lack of a better term. And then we have the third group who is still symptomatic, but is coping, and then I'm going to show you a couple of cases and share with you a couple of cases where we goofed at the FAA. And, this is a complicated problem, and there's no easy answer, I think. So what else do we have about ADHD? Well, we have spec sheets, so the neuropsychologists have some consistency in the way they work up these cases. We do require drug testing after the neuropsych testing, just to make sure that someone hasn't decided to performance enhance their performance on the neurocognitive testing. For those interested in why we are so concerned with this, I would refer you to this article from the Aerospace Medicine and Human Performance in 2017, where they looked at a period of time, 5 years' time in the NTSB database at fatal accidents, and found, in fact, 9 were associated with this diagnosis of ADHD. Concerning, because not very often does NTSB go on record regarding medical or mental health issues. I mean, is common, okay, loss of control or, those things, what finally put the airplane in the ground. but they are reluctant to stick their neck out, go on a limb about why there was a loss of control. So this is significant that they actually identified ADHD as a possible contributor to these fatal accidents. So with that, here we go. Let's look at a couple of cases. So case one, 35-year-old software engineer. He received an unrestricted Class 3 medical certificate in 2019. At that point in time, he was not on any medications. He was involved in a fatal aircraft mishap in 2020. He was advised by the FBO that he should delay his flight due to storms. Weather advisory was in effect for his route of flight, and in fact, there was no recorded weather briefing before takeoff. Bad pilot judgment, but impulsiveness related to his ADHD? The NTSB thought so. So let's look a little deeper at the history here. So this individual was diagnosed in childhood with ADHD, was treated through college, also had academic accommodations, and then was treated intermittently in the years following. But he also was using on-the-job accommodations, doing those things that took more concentration and focus when he felt more concentrated and focused. And so he was able to manipulate his workload to accommodate his condition. So the neuropsychologist in 2019 confirmed the diagnosis of ADHD. And his comments were impaired attention concentration, and watch this one, balanced by good performance on other test measures as well as his occupational history. So this was not a strong statement here, a little equivocal as we get this in the FAA and look at it and go, But balanced by his occupational history, he's a software engineer, he's doing well. So what did we do wrong? Okay, we failed to note the requirement for job accommodations. It was unclear when we looked at the case that that was going on. It's amazing what NTSB can find out that we don't know, because they can subpoena records. I think our fatal assumption here was because this pilot was successful in his professional job, then his symptoms of ADHD must no longer have been significant. So, a worry. Let's look at one more. How about a 47-year-old self-employed plumber? He was originally denied his medical certificate in 2014 because at that time he was being actively treated for ADHD and was on Adderall. So what does any good aspiring pilot do if they think, oh, I can't get my pilot certificate because I'm on Adderall? Well, I quit the Adderall. So yes, indeed, he did. And he came back and got an unrestricted Class 3 certificate in 2016, at which time he was off medications. He was involved in a fatal aircraft mishap in 2017. So what did the NTSB have to say about this? Well, this was a non-instrument rated pilot with inadequate pre-flight planning who entered IMC and had some light to moderate icing, spatial disorientation, and loss of control. Okay, but why? Pilot judgment again. And was this impulsivity? Was this related to his ADHD or was it not? And they thought there was a significant evidence that it might be a contributing factor. So, looking again a little deeper into this case, what do we see? Well, this individual had difficulty staying on task, was distractible, he repeated the 5th grade, was a C/D student in high school, but had a high average IQ. Successful business owner, had 84 employees working for him. Okay, but if you go and talk to those employees and associates, they complained to him that he had poor memory and distractibility, and to the degree that he was concerned enough that at the age of 36, he went and talked to his primary care doctor, who put him on medication. Well, a little unusual to come down with that diagnosis and start treatment for the first time at age 36, but that's what we have here. Inadequate records. There was no evidence of a ADHD workup. We had no academic records available to us at the time we looked at the record, and also not any of this collateral information from the employees or his company. It was actually his wife that was really running the company. So once again, we were lured into our error here by, well, this individual must be okay because he was a successful business owner. So I think the real message here is that we have to get beyond the superficial, and we really have to look into these cases. And this takes time, you know, it takes honesty from our folks, and hopefully we won't get it wrong in the future. So what can you do? Well, number one, I would ask you, as I did last year, don't perpetuate myths. You know, if there's a question, if somebody says something to you that doesn't sound right, you know, I've got a whole staff of mental health professionals. There's my email address. Send me, you know, say, hey, I heard this. Is this right? You know, before we disseminate it. I mean, I actually did, in fact, get a follow-up email from one of your students last year and was very happy to get that. What else can you do? Trust goes both ways. You know, we talked this morning again in our discussion group about, well, you know, we're not sure we can trust the FAA. Well, what does that mean? Okay, well, I think maybe it means that folks can't trust that they're going to get the answer they want. But I'll take you back to the first slide. I mean, safety is job number one. But so often, you know, we're having to sort out records that are incomplete, where the history has been minimized, where the pilot applicant has denied, and, you know, we need to somehow get it together better and understand that we can trust what we're getting in history, and then we can ask for less history. So then, you know, that's what everybody wants. They want to be able to go out and get help and not have to wonder, okay, you know, do I have to tell the FAA about this? We should someday hopefully be on a level where this communication is shared and honest and open. Be alert. You know, again, I mentioned this last year. This is more common, and I think everybody knows it. You know, mental health issues are more and more common. Our requests for psychiatric review of cases doubled between the last 2 quarters of fiscal 21 and the first 3 quarters of fiscal 22. And again, that's part of the reason why we've had to increase our staff. There is a lot of this out there. Now, is it because there's more stress, pandemic, you name it? Whatever the reason, it's increasing. And finally, you know, take action. Do something. Don't just let it ride. If it's for yourself, if it's for a colleague, and there's a whole range. I mean, you don't have to start with the mental health professionals. I mean, I'm of the impression that Dr. Snyder showed our little rainbow chart with the continuity between wellness and frank illness. And we want to move taking action earlier in the process so that it can be dealt with at a much lower level. So with that, I think we have time for questions. Beth?
Can I grab a microphone? If there's any questions from the audience?
Oh, okay.
Hi, thank you. I wanted to ask if you could go back to the HIMSS slide where you showed the increasing number of HIMSS pilot participation. And then the question I had on that is there research being done to look into the causal factors that are behind the increasing numbers of pilots partaking in the HIMSS program and suffering from substance dependence disorders? And if so, is the FAA doing anything or putting any type of encouragement out there for airlines to be sort of addressing some of those common denominators that might be being found?
Well, we kind of get involved in these late in the process. As you well know, most of the airlines that have formal HIMSS programs, and again, that's where this data is coming from, they work with the identification, they work with getting their pilots to treatment and aftercare and the other things that we're looking for. So we see these applications and become aware of these people late in the process. I am not hearing anything from the airlines except that they're saying they're seeing people more severe now than they were. But I'm not aware that they're doing anything differently than they were. Quay may be able to add something here. For example, at our last HIMSS chairs meeting, one of the airlines mentioned that they had 9 folks in detox over the course of the previous year. And prior to that, they couldn't hardly remember the last time they had even one. So I think the isolation, I think the pandemic and people being on their own and drinking more accelerated disease in some folks, and they weren't, out there with their peers with a chance to be recognized that, hey, are you doing okay kind of thing. But no, I am not aware of anything that we're particularly targeting as a cause that we might intervene with. Quay, are you? I think you have a mic. There we go.
Yeah, I have a microphone. So I think there's a couple of phenomenon here. One is actually a reporting phenomenon. What Dr. Giovanetti said is exactly correct. We're not seeing an increase in the number of pilots so much as an increase in the severity that they're presenting with. The numbers for pilots involved in the HIMSS program amongst the various airlines run about 1.5% of the pilots. It runs from 1 to 2% in most airlines are involved in the HIMSS program. But also this coincides a little bit with an FAA change in policy regarding the length of monitoring and what's known as the step-down program. So I haven't discussed this with Dr. Giovanetti about whether this represents more special issuances, because the step-down program generates a requirement for a different special issuance each time a pilot is released from some of those requirements. Previously, the follow-up was generally 3 years and then 5 years if it was recurrence or drugs. But now the minimum follow-up period in the step-down program is 8 years. But there are 3 steps that people go through after their initial special issuance. Each of those generates a new special issuance. So what we may see is a phenomenon of more people being followed for a longer period of time, getting more special issuances because of the reduced requirements that they're getting over the years. But I haven't discussed this with Penny. This is the first time I've seen this slide.
But I surprised you for once.
You did, and so we're even, because I always usually surprise her. But I will say that we have steady rates of participation with the pilots, but also this year in the HIMSS program, we saw a dramatic increase in the amount of management pilots who are attending, chief pilots, directors of flight operations. We usually run about 20 in our seminar. We had 58 this year. So I think that reflects an increased interest by the airline management, as well as the pilots have always been full in with this, but the airline management in recognizing that the problem exists and addressing it earlier, and perhaps having a lower threshold for a benign, safe harbor type intervention for pilots.
Yeah, Quay, and what I'd add is the step-down program was started in 2020. So that would be a very good explanation for why we have a higher total from 2020 to 2021, but that would not explain, the already linear increase pattern in the years prior to the pandemic. So I would hope, the most optimistic explanation for this is, yep, folks are coming forward. They're not hiding under a rock somewhere, but I don't know that. Other questions?
Thank you,
Yes.
Dr. Giovanetti. So I'm encouraged by the increase in the number of pilots that we're seeing are making their way through the SSRI process at over 1,500. That's certainly an increase from the 2018 stats that are on the FAA website. Can you give a flavor of how many have actually applied in terms of what's that approval percentage kind of looking like for those that are on an SSRI pathway?
We haven't been able to break it out specifically by diagnosis, by SSRI. So what I gave you was kind of the whole pool of anything with a mental health diagnosis, which also could mean, the disqualifications in that statistic could be for the medical side in people who are dual diagnosis, so to speak. So if somebody had a history of an MI and a history of major depressive disorder, they would have popped out here as one of the DQs, but it wasn't the depressive disorder that was the cause, it was the MI. No, we have to do it by hand if we want to have any kind of accuracy by diagnosis. We have to look at every single case because our pathology coding system and the database system that we have is really set up for workflow and not for research. So I can't give it to you on SSRI.
Okay, and thanks for that. And do we have any sense of just the overall reported diagnoses for mental health, whether that's depression or any of those, or is that even possibility to report on those kind of things too, just to understand relative to statistics to the broader population and understanding sort of what are, how well is the reporting sort of going on the certificate process?
I'm not sure that I exactly understand the question. So we did at one point several years ago do a study and we looked at everybody in the SSRI program and why they were taking the SSRIs. And there's a whole list of different diagnoses for which you might be taking SSRIs. But we haven't updated that data lately either. So I don't know that I got your really
Sorry, and I
answered
wasn't
your
clear on
question.
kind of the second question. So even beyond those taking an SSRI, simply those that are reporting on a medical certificate application, diagnosis of depression or of anxiety. Let's just say even start with those kind of two. Is there any way to understand that data, or does that exist within the system?
We would have to hand look at it again. Are you asking like what percent are reporting depression that doesn't turn out to need SSRI treatment or doesn't need a special issuance, or?
No, just generally trying to understand those sort of coming forth and indicating those diagnoses on their applications.
Oh, as
relative
opposed to
like if we
not
went to go
reporting
compare
it.
that to CDC data or Substance and Mental Health Abuse Administration data, just in generally understanding mental health.
We
broadly
have
on
not
the population.
specifically done that, although we have a sense, at least with the HIMSS substance stuff, that it seems like we have fewer than you would predict based on the general population.
Okay.
Now, whether that's a reporting phenomenon or whether that's because we are a selected group as pilots, that I can't answer.
Okay. Thank you.
Sorry, I forgot to elaborate on the really good news about this chart that's up there. And another part of this is this chart shows those pilots that are in an airline with a HIMSS program. And what we have seen over the last 5 years is an increasing number of airlines and thus a larger pilot population eligible for this type of program. We went from about 26 airlines that were actively participating approximately 5 years ago to now I believe it's close to 40. So there is a larger population that's being captured with this opportunity.
Good
Thank you.
point. Good point.
Mark's behind you.
I was wondering, is there a formal way that the timeline is being tracked from when your medical's originally deferred to when you're finally issued your special issuance?
Oh, yes. I looked at that on a regular basis.
Okay, and you said that was 6 months? Or is that just for the initial, when that file is reviewed for the first time?
Right now, the wait time when a case needs to have psychiatric specialty review is about 6 months. So they're working cases that are about 6 months old.
Okay, and what is the timeline for when that person is handed their special issuance?
Well, that 6 months is kind of from when we get the case to when we make a decision.
Okay,
So, yeah.
got it, thank you.
Any other questions?
I just had almost a similar related question to mental health, but not really. So in terms of HIV, pilots with HIV, there's still the requirement for pilots to conduct a neuropsychological evaluation, despite the treatments modern treatments of HIV not having that effect of AIDS-related dementia. So could you explain the backing for a neuropsychological evaluation for pilots with HIV?
I sure can. As a matter of fact, we looked at that very thing about, I want to say, 2 years ago and reevaluated, because prior to that had been, almost like 10 years, and treatment for HIV, as you well know, has really changed over time. And what we concluded was that there is still a significant risk of developing cognitive effects, even when the viral loads are low and the CD4 counts are okay. So we've continued. We had looked seriously about decreasing the frequency of that and decided against it.
Thank you very much.
You bet. You guys are easy. That's it? No more?
Here we go.
There's one.
Thank you so much for all the information you've provided today. It's been really insightful. I'm kind of curious, coming from the student side of things, seeing the trends in applications and the increase in mental health in those applications, how do you think that that's going to affect the need for pilots over the next few years? We talk about, the great pilot shortage. We never have enough pilots. How do you think that, more people trying to become pilots, maybe having mental health issues is going to affect, the demand that we need?
If you look long-term, and this is my personal opinion now, so do not blame the FAA for this. I'm not sure that we're putting enough emphasis on the technology side. And what I'm seeing is a movement toward smaller cockpit crews, toward fully automated flight, and how fast that comes, how fast that gets public acceptance is hard to say, but I think this current pilot shortage is probably somewhat short-lived. We are looking at assessing aeromedical risk not as medical risk alone, but as risk in the context of the entire system. And so if you have, for example, business jets, which are capable of detecting that a pilot is now totally incapacitated, okay, HAL takes over, lands the airplane. You can make very different medical risk decisions when you factor that in. So we are having those discussions actively at the FAA now.
Thank you.
You bet.